morning. We'll get started. And welcome to the American Academy of Neurological Orthopedic Surgeons. And we're very pleased to have Dr. Biswas here today as a general surgeon, and he's speaking on rib plating. He's trained in trauma, educated in India and Johns Hopkins. I spoke with him a little bit yesterday and today, so my first time meeting him. But yeah, welcome, and you're free to start. There it goes.
Good morning. As a general surgeon, it's a privilege to have the podium, the honor of the podium here amongst the neurosurgery orthopedic group. And, my topic is rib plating, and we've been doing rib plating for some time now. But most of the rib platings have been done on patients who are relatively young, and so the recovery is very good. But now with the technology getting better, we are doing more and more in elderly people. And previously the thought was elderly people are have significant comorbidities, so they are risk factors and stuff like that. So we were initially reluctant to do those cases. So my talk is going to be on Nonagenarians and Octogenarians over 80 and 90 years of age. So as you know, the whole world population is getting older by the day, and more so in America. And so by 2030, you can see here, 1/6 of the population will be about 60 years or more. And 2050, the people over 60 years will be doubled to 2.1 billion. And then to 2020 and 2050, the number of people over 80 years will triple to 4.6 million. So that's a significant number. And today we're going to talk about this super elderly group, which is the 80s and 90 years of age. So as I discussed briefly in my introduction, that as we grow up with this elderly people, there are multiple cofactors which come into play. And those are chronic conditions like COPD, diabetes, dementia, cardiovascular disease, significant comorbidities, especially in the perioperative period. They become frail, and that adds to the problem significantly, adds to their disability, adds to their hospitalization, poor surgical outcomes. And then they basically end up in the hospital for multiple frailty-related conditions like hip fractures, TBIs, and significant functional decline as you age. Again, it says more of morbidity and mortality associated with age, and then there are poor outcome with rib fractures at this age group. So this is a review article which shows that as we grow older and progressively there are significant amount of injuries and stuff. So in this paper, which is a scoping review, this is somewhat old paper. Between 2000 and 2022, they found out almost 57 publications being done, but there were some issues with a generalized systematic approach to the management of elderly rib fracture patients. But in spite of that, they found out all these people have significant injuries associated with rib fractures. So they have TBI, they have hip fractures, long bone fractures, and so on. All required going to the operating room pretty early, or even a prolonged ICU stay. But they found out treating these patients in a trauma center, especially in a level 1 or level 2 trauma center with special geriatric age group management and multidisciplinary approach, had good outcomes in these patients. So here is an algorithm. So in my previous slide, I said there's some discrepancy as far as management is concerned. Previously, the thought process was that there are high risk factors, do not go and operate on them. The management was mostly conservative. Now the American College has significantly been involved, and this rib plating has come back in a big way. And so now they come up with an algorithm which says specifically what the injuries are that we need to do for rib plating and the risk versus benefit. So chest wall instability is one of the important factors, and it says obviously clinical flail segments, generalized clicking and popping, chest wall deformity with intercostal herniation, rib fractures with internal injuries. Those are the ones which definitely will benefit from rib plating. Some of the things that which are other factors which we normally take into account when we are making a decision about rib plating are radiological flail with more than 3 rib fractures with more than 50% displaced, or with 2 factors and with pulmonary derangements. Some of the factors are respiratory rate more than 20, the IS is less than 50% of predicted, and pain score more than 5, and poor cough. We call it the FICS score, and we measure the FICS score every day in the ICU, and we normally make it a point to admit this patient based on the number of fractures more than 3 to ICU for initial management. So here the rib plating on post-op outcomes in patients who are elderly group, but 65 years or more. So we call them the elderly group, and it says some of the papers that has come up with the same sort of a thought process that they benefit from operative management, and they seem to do well with operative management. So post-op outcomes in these patients, so we can see that overall the decreased ICU stay and hospital stay, decreased ventilatory requirements, provided we do early appropriate interventions, decreased pulmonary complications, and decreased long-term pain medication requirements. All of them are pretty significant factors. And obviously, most importantly, decreased mortality. But what about the extreme elderly, the very elderly in their 80s and 90s? Previously, we were a bit reluctant to operate on them. And this is a real-life picture of one of my patients we operated. She was 97 years of age, and she had a fall, a ground-level fall, but she broke significant ribs. And I initially refused to operate on her, but her daughter, who is an ICU nurse, insisted that we operate, otherwise she's going to die anyway. She was ventilated with multiple days and stuff, not getting better at all. So we operated on this, and she made a wonderful recovery. 3 months later, she was in the clinic with a walker, with minimal pain medications and stuff. So these are some of the factors we take into account when we're dealing with elderly people. So elderly people, we need to do a proper pre-operative examinations and clinical evaluations before we operate. Those are very important, and because not everybody will benefit from an operation, and so the pre-operative evaluation is well. So keyhole operation is coming to vogue. So thoracoscopic operation with rib plating is done now more and more. Minimally invasive, we try to basically minimize the incision to minimal. Even we're doing a thoracotomy, we're trying to minimize, and we're using more of muscle sparing instead of muscle cutting, and try to get maximum exposure with the use of Alexis, as you can see in this picture. And obviously, the pre-operative evaluation is of significance. Here, it shows some of the points that we keep into account, like the plate thickness. We have been using recently of late plates with a color coding, which gives us a color coding of the length of the ribs we want to use, and that depends on the number of ribs that we are plating, and which rib is that we are plating, whether it's anteriorly placed or posteriorly placed. I'm going to talk about briefly in the later slides about pre-operative 3D recon and stuff like that. But here, the fracture gap should be in the middle between the 2 ends of the plates, so that the results are the best. And we have to choose appropriately the screws and stuff like that. Stripping of the periosteum, we try to prevent it as much as possible. Obviously, exposure sometimes can be difficult, especially as the time frame increases, like from the injury to the operative. So that's the reason like we try to operate as soon as we can within the first couple of days. But other than that, like callus forms and periosteum, we normally try to preserve it because that helps in the later on healing process. Some of the difficult situations that we encounter, like underneath the scapula, very posterior location near the spine, multiple fracture lines, and we come up with like different techniques and different strategies to counter them. We use like plates which are fatigue free. This is like made of an alloy called PEEK. I'm going to talk about that like a few seconds there. Costochondral involvement is a major problem, and they are not picked up well in the CT scans. So that is always a big problem. We do like a 3D recon that gives us a better picture prior to operating, because CT scans with 2D pictures are not always sufficient for getting us a good roadmap. Here are like some papers which show that elderly people, especially the Nonagenarians and Octogenarians, are somewhat difficult, and the surgical trends of them obviously is somewhat different, with a higher perioperative mortality and longer post-op hospital stay. Same here, this is like a quote from the Mayo Clinic bulletin, which says that like one simple rib fracture in a 90-year-old is equivalent to 8 rib fractures in a 40-year-old. So obviously the impact is significantly different in those people. This is like a landmark paper. Unfortunately, not much is written about this age group rib fractures. I think I could find only like 3 or 4 at the most with retrospective studies. And this is like one of the landmark papers from Denver, and which says that like this was a retrospective cohort with 8 centers found out from stabilization of ribs from 2015 to 2020, and they did a subgroup analysis into early and late, which is like between the injury to second day and then late to 3 to 7 days. And they found that like the decreased risk of mortality for the surgically operated group compared to the non-operative group. This is like the one I briefly talked about. This is an alloy. It's normally when we use the titanium plates, they can have fatigue, and the screws can get dislodged, and the plates can get dislodged, especially in this age group where there are very osteoporotic bones. So PEEK is a new generation alloy which has come into play. It's very thin and very light, and definitely helps in those, and it prevents against fatigue. This is like some of the pain medication protocols we use, intercostal cryoablations, and this has come into play, and we've been using it more of an adjunct, because as we grow older, like narcotics become a problem, and so we're trying to basically cut down on narcotics with the using of those cryo. It can be done either externally, or we do with our VATs internally to the thorax. So this is the zone. It should be like 2 centimeters from the ganglion. This is the green zone that we normally do, and we normally take into account like from 4th to 8th rib fracture, the intercostal joints, because below that we can cause pseudo hernia, and above that we can cause ptosis. We did have like a couple of cases of that. So surgical stabilization, as you can see here, combined with intercostal nerve block, it gives a significant amount, like almost like 3 to 6 months of pain relief in some of the patients. So it's definitely helpful. And then it, in the meantime, like obviously has cost benefits, because it decreases your length of stay and post-op hospital stay. Now we've gone a step farther. Now we are using, even without rib plating, percutaneous cryo in traumatic rib fractures, which we're using with ultrasound-guided probes, and we are doing by the bedside without any rib plating. So the patient doesn't need an operative intervention. We are using it more like a direct pain medication. So these are like some of the adjuncts I was talking about. We definitely do a 3D recon for our pre-operative planning before going into those patients. We obviously use the anatomical landmarks, from the spine, from the tip of the scapula, and that gives us a bit location. We do an ultrasound before the operation proper, just before the operation. That gives us an exact localization, and we mark it prior to the incision. These are like some of the developments in real life, real time, like now. And bigger centers are trying to use it more and more, although like we haven't used it ourselves because of like certain issues like HIPAA violations and patient identifications and stuff like that. But this has definitely come into play where VRs are used and augmented realities are used, where you can pre-operatively plan for those. I know like orthopedics does use that in multiple centers, but we still haven't used it yet. But it's definitely in vogue now. And 3D printing also is back in vogue, and especially with complex rib fractures, where you can do a 3D reconstruction prior to the operation, and then the night before you can basically plan your operation according to that. Pros and cons, we can have like intraoperative time benefit. We can do a custom fit, which is of significance, especially in this elderly age group where you have to have a proper fit and cuts down on the time, and diminished manufacturing waste. And then cons are more planning time, your motor development and time, intensity and costly obviously, and not available everywhere. And emergency cases, obviously those needs to go to the OR. Obviously we don't have the time for those treated cons. This is another topic which is like it's going to come in sometime soon. This is a website which basically you go in and you log in the information about the patient, and you can have a pre-operative planning of like how to operate, which ribs are the fractured ones, how much displacement. That will help you in choosing like which plates to use, and what is the thickness, and what are the screws you're going to use and stuff like that. So that is significant in those cases. Here is also the VR planning the night before. You can basically map out what exactly is the fracture, how much is the displacement. It helps in identifying the number of ribs very, very precisely, and obviously helps significantly. But again, this is not available everywhere. We are still in the learning process, and still but we definitely are optimistic that with time this will be easily available in most places. As I've discussed before, procedural simulation is of significance. Pre-operative strategies are very, very important because it cuts on cost, cuts on anesthesia time, and optimizes your resources, anatomical accuracy, and shorter operative times. All of them helps in the post-operative outcomes of these patients. So looking forward, we need to keep an eye on the risks and benefits of this surgical stabilization versus the replating, especially in this elderly age group. But we need to pick and choose the patients who will benefit from this operation, because they are high risk with multiple comorbidities and frailty factors. And so more studies obviously needs to be done. Thank you. I appreciate your time.
I noticed you had a round retractor on one of your earlier slides. What is that ring you're using?
So it's called an Alexis. It's not a retractor. It's basically, we use it for abdominal surgeries because especially hand-assisted laparoscopy. So we, instead of basically making a big incision, it prevents against SSI. So we normally, it has like two solid ones in either side and a plastic in between, and you can roll it like that. And it's a double shape. So you basically put it in, and we have been trying to use this in rib fractures more and more because it isolates the field and prevents against SSI and infections and stuff.
Okay. Another question. So some of your images, you noted there was a kind of a deformity, an overlap of the ribs. What are you using to kind of realign that? I mean, are you?
So we normally realign them as a normal, as any orthopedic injuries more or less. So we have a rib lock system where we normally retract them, put it back in place. And then the system we use for rib fractures, they are like plates with a C in either side. And then when you put in the C, you first obviously reduce it so that it's aligned. and then you put in that C, and then you have screws in the suite. So when you screw in that C, that reduces and keep it reduced. And then you take those, they're like, I can show you that picture, like you have like a big long pillars like thing, which you are detachable. Then once it's reduced and you screwed it in, you normally detach it. So.
If there is a rib defect, can you plate and then put grab or something like that?
Yeah, we've been trying to use like grabs, but there's like we have to do resection and stuff, especially in trauma, but there are gunshot wounds, and we have been using something called montage, which orthopedics uses it for like tibial fractures and stuff. If it's a small gap, we can use that in between, and it is very good because like with few minutes, it becomes solidified, and we normally put in a screw through that also. So you have like stabilization on either side and screw through that montage also, which is also. And you can use like fibular implants and stuff, iliocrest implants. Yeah.
For the cryoablation, is that like with a ball tip
Yeah.
in the field there?
So we normally do VATS for all of them, proctoscopic evaluation. Because most of these people have a amount of blood there in the chest, and that will cause like fibrothorax down the line. So we normally do a VATS after the case, after the rib plates, and usually we try to do it like a double lung ventilation, and with one lung down, because like we don't want to go into the pleural space when you're operating and the patient decompensating. Sometimes it can be a challenge because this elderly age group, they're already compromised and they may not like tolerate one lung ventilation, but we try to do it like the VATS.
Very good.
Thank you.
Thank you.